Hello friends, today we are going to discuss about intra-abdominal hypertension. So intra-abdominal pressure is defined as the pressure created within the abdominal cavity. The normal intra-abdominal pressure for critically ill patient is 5 to 7 mmHg. Intra-abdominal hypertension is sustained or repeated if intra-abdominal pressure is repeated intra-abdominal pressure is more than 12 mmHg. So, according to the pressure, there are various grades of intra-abdominal pressure. Like grade 1 intra-abdominal pressure is 12 to 15 mmHg. Grade 2 intra-abdominal pressure is 16 to 20 mmHg. Grade 3 intra-abdominal pressure is 21 to 25 mmHg. And grade 4 intra-abdominal pressure is more than 25 mmHg. If intra-abdominal pressure measurements are more than 12 mmHg and less than 20 mmHg, then it is suggested that intra-abdominal pressure for measurement should be done 4 hourly. So the first one is related to the diminished abdominal wall complex. That is high body mass index, pregnancy, mechanical ventilation, use of P for when auto PP is present, basal pneumonia, pneumoperitoneum, then abdominal surgery, particularly when tight abdominal closures, pneumatic anti-shock garment, prone positioning, abdominal wall bleeding or abdominal hematoma, burns with abdominal estuaries. Related to increased intra-abdominal content, that is gastroparesis, gastric distension, ileus, volvulus, bowel pseudo-obstruction, abdominal hematoma, intra-abdominal or retroperitoneal hematoma, damage control laparotomy, liver dysfunction with ascites, abdominal infection, hemoperitoneum, pneumoperitoneum, major trauma, excessive inflation during laparoscopy, and peritoneal dialysis. Then the factors which are related to capillary leak and fluid resuscitation. That is acidosis, hypothermia, coagulopathy, multiple transfusions and trauma that is more than 10 units in 24 hours, sepsis, severe sepsis or bacteremia, septic shock, massive fluid resuscitation and major burn. Now, how to measure intra-abdominal pressure? So, measurement of intra-abdominal pressure is simple, inexpensive, safe, and accurate method in determining the presence of intra-abdominal hypertension. This measurement can guide the patient measure. The range of approaches to measure intra-abdominal pressure include intragastric, intrarectal, inferior vena cava, or via urinary indwelling catheter pressure monitoring system. It is recommended to use modified Cron technique, which is the gold standard technique for IAP measurement. Cron method to assess the intra-abdominal pressure via bladder pressure measurement using maximum installation of the 25 ml of sterile saline. So how to measure this? So with transducer zeroed and position in line with iliac crest and mid-axillary, patient should be in supine position. It is measured in the end expiratory phase with installation of the volume no more than 25 ml of saline. 30 to 60 seconds after installation, allow a bladder detrusor muscle to relax. The technique of continuous IIP monitoring has been suggested to be superior than the intermittent technique. The continuous method allows for the continuous analysis of IIP via bladder and eliminates the risk of missing elevations in IIP due to timing, which can occur with the intermittent technique. Continuous methods have been used via gastric route and invasive direct measurement. But measurements using this technique showed the poor reproducibility. However, recent studies showed the comparable result between traditional Cron technique and continuous direct intra-abdominal technique. The agreement of continuous bladder IIP measurement to the current gold standard of intermittent measurement is reliable. A continuous IIP measurement technique requires insertion of more expensive three-way catheter that could be cause of its limited use. There is also range of opinion regarding the volume of fluid required to be instilled into bladder to format accurate pressure reading. Volume as low as 2 ml have been used to measure intra-abdominal pressure, and results are comparable to the use of 25 ml of normal saline. Fluid volumes above 25 ml have potential to mislead treatment due to overestimation of intra-abdominal pressure. Current guidelines suggest the maximum volume of 25 ml of fluid be instilled into bladder for intra-abdominal pressure measurement. There are a select few patients in whom intra-abdominal pressure measurement via direct bladder method is not feasible, which include ruptured bladder, intrabladder hematoma, neurogenic bladder, recent bladder surgery, and urogenital anomalies. So now next is what is abdominal compartment syndrome. Abdominal compartment syndrome is defined as sustained intra-abdominal pressure greater than 20 mmHg with new organ dysfunction or failure regardless of abdominal perfusion pressure. Now, primary abdominal compartment syndrome occurs as a result of injury or disease to abdominal or pelvic region that frequently requires early radiological or surgical intervention, or conditions that develop post-abdominal surgery requiring surgical intervention. Included in primary ACS are patients who are managed non-operatively for organ damage, who then go on to develop ACS. Then this category can include patients with abdominal trauma, abdominal region, retroperitoneal hematoma, and those associated with damage control during laparotomy procedure. Secondary ACS is an often unavoidable progression of ICU patients' pathology and refer to conditions that do not originate from abdominal and pelvic region. Secondary ACS occur in the absence of any abdominal injury, and this can include patients who have sepsis, pancreatitis, and have had excessive fluid resuscitation. Recurrent ACS is the reoccurrence of ACS after surgical and medical treatment of either primary and secondary IVH, intra-abdominal hypertension, and abdominal compartment syndrome. Now, the next concept that we need to know is abdominal perfusion pressure. Abdominal perfusion pressure has been identified as an indicator of adequate abdominal perfusion. So the abdominal perfusion pressure indicates the pressure available for perfusion of intra-abdominal organs. So how to calculate this? So we can calculate this by formula, that is mean abdominal pressure minus intra-abdominal pressure. Now, abdominal perfusion pressure has previously been suggested as more accurate indicator of intra-abdominal hypertension severity and indicates the degree of abdominal tissue perfusion. Abdominal perfusion pressure should be maintained between 50 to 60 mmHg for patients with IH who do not require immediate intervention. Patients with intra-abdominal hypertension who are unable to maintain abdominal pressure above 50 mmHg require surgical intervention. More recent studies have suggested that patients with abdominal perfusion pressure greater than 60 have shown reduction in the incidence of renal failure. Indications for IAP monitoring. There is considerable debate regarding the applicability of absolute IAP ranges in the management of critically ill patients. As suggested by multiple authors, intra-abdominal pressure more than 20 mmHg can cause significant physiological disturbances in critically ill patients. However, there are also patients with the same elevation in intra-abdominal pressure showed no such derangement. Due to differences in the clinical presentation, there appears to be the lack of clinical awareness, hence failure to recognize intra-abdominal hypertension and abdominal compartment syndrome. Identifying patient at risk is the initial step in the recognition and diagnosis. It is essential that patients are screened for the presence of intra-abdominal hypertension and ACS upon admission to ICU, and additionally the presence of new and progressive organ failure. It is suggested to assess the risk factor for IH and ACS upon admission to ICU and for duration of patient's critical illness. Post-assessment, if there are two or more risk factors present, or there is a new or progressive organ failure, then baseline IAP measurement should be taken and then assessment algorithm should be implemented. If IH is present, then medical management should be implemented to reduce intra-abdominal pressure. Measurement should be taken 4 to 6 hourly or continuously. For patients with elevated intra-abdominal pressure, monitoring should occur throughout the patient's critical illness. There are recognized independent risk factors for development of intra-abdominal hypertension and abdominal compartment syndrome. In addition to the independent risk factor for intra-abdominal pressure, monitoring is also suggested for patients with open and blunt abdominal trauma, those who have high body mass index, and those who sustain burns and or hypotensive for whatever reason, and those patients with mesenteric ischemia or patient with uh, elevated IC. So regarding organ function, due to adverse effect of intra-abdominal hypertension and ACS on patients' morbidity and mortality, there is need for advanced practices, nurses to assess and manage patients using evidence-based protocol. Patients with ACS are often managed with pharmacological, technical, and medical and surgical procedures. Pharmacological support for patients with intra-abdominal hypertension and ACS is multifaceted and entails active and precise fluid resuscitation to maintain adequate circulating volume without fluid overloading, medications to support cardiac output in the event of decompensation, and antibiotic to treat infection. In the context of critical illness, technical support involves ventilatory support, continuous renal replacement therapy, invasive cardiac monitoring, ABG, blood glucose monitoring, and treatment of electrolyte disturbances. So these are the adverse effects on the various organs which is caused by the raised intra-abdominal pressure. So we'll see what are the effects on the CMs. An increased intra-abdominal pressure forces the diaphragm up, decreasing the intrathoracic space, increasing intrathoracic pressure. Because of that, regular pressure increases, vascular venous return will decrease, and intracerebral pressure will increase. The cerebral blood flow will decrease as a result of this. Then the effect on cardiac function. An increase in intra-abdominal pressure causes the increased pressure on inferior vena cava, intra-abdominal circulation, and perfusion. And the venous return is impaired and peripheral edema will occur. And there will be the increase in central venous pressure. And also there will be the increase in pulmonary artery wedge pressure as myocardium is placed under the increased work. So what are the effect on the respiratory function? An increase in intra-abdominal pressure forces the diaphragm up, decreasing the intrathoracic space and restrict the respiration. Result in increased intrathoracic pressure, particularly with mechanically ventilated patients. If it is left uncorrected, it will result in decrease in compliance and decrease in functional residual capacity, vacuum mismatch, and hypoxia. Then effect on kidney will be oliguria and anuria despite aggressive fluid resuscitation. Increased abdominal pressure decrease the renal blood flow coupled with reduction in cardiac output. The renin-angiotensin system is activated further, adding to intra-abdominal pressure and cardiac work. Increased intra-abdominal pressure results in increased vascular resistance and decreased cardiac output. Result in decreased tissue perfusion and ultimately tissue ischemia. Now regarding peripheral perfusion, increased abdominal pressure is said to increase femoral venous pressure, increase peripheral vascular resistance, and reduce the and it will causes the reduction in the peripheral perfusion. Now regarding the non-surgical management, non-surgical approach is used when in patient with no abdominal injuries, and it may involve the insertion of percutaneous drain for fluid removal. Current guidelines suggest that when IH or ACS has been established, intraperitoneal fluid have been confirmed, and the percutaneous drainage should be undertaken as it may negate the need for decompressive laparotomy. Other measures include judicious use of fluid, endogastric tube insertion, laxative usage, pain relief, and muscle relaxation. Other measures such as CRRT, diuretic, albumin are being used to manage the patient. And one more non-surgical method is damage control resuscitation, which is characterized by the permissive hypotension, limitation of crystalloid infusion, and admission of higher ratios of plasma and platelet to RBC. So it is recommended to use higher ratio of plasma and PRBC as opposed to limited or no use. Now regarding surgical method, surgical management involves decompression of the abdomen. Decompression occurs in cases of trauma with abdominal injuries or where the patient's clinical condition continues to deteriorate while using non-surgical management techniques. So decompression is aimed at restoring organ perfusion and ultimately organ function. Early surgical decompression of the abdomen is considered therapeutic intervention, and it is a definitive treatment for ACS and is performed when ACS is unresponsive to medical treatment option. There is recommended This is recommended despite reported complication and 50% mortality rate. Decompression often results in abdomen being left open, followed by other surgical procedures. Presumptive decompression should be considered at the time of laparotomy for patients who demonstrated risk factor for ACS. After a decompression procedure where abdomen is left open, there is limited literature guiding definitive abdominal closure. So it has been So current guidelines suggest this method should be used when the patient is physiologically fatigued, with abdomen to remain prophylactically open to avoid intra-abdominal hypertension. Thank you, friends.